liking sometimes is making decisions that might be difficult from a business standpoint, but what from a patient and provider standpoint are paramount to what we do here in increasing our outcomes and maintaining a good reputation of being ethical and honest about how we do things. Because let's be honest, this top word here, although it gets a bunch of people's attention, the stem cells, it has a lot of negatives with it as well, right? So there are a lot of people out there that are using quote-unquote stem cells for treating all sorts of things, whether they be systemic diseases or some of the stuff that we do, pain, arthritis type stuff. And I'm not 100% sure that what they're using has any stem cells, to be honest, right? And a lot of the stuff that we use doesn't have stem cells in it. But guess what? You don't have to have the cells to do the work. A lot of times you need the growth factors, you need the proteins, you need the scaffold of the what we call the soup, right? So the stuff that allows your body to heal, that stimulates your body to do the work. And I think what sets us apart, you said, and I appreciate it, top 5 in the country. I don't know that that's true, but I will tell you that I am in the top tier of people in delivering these types of products to the patient, right? Learning how to pick which products is one of those things you kind of learn through experience and through colleagues and other people's experiences. But learning how to deliver these types of products accurately to the problem area, that's where the real, that's where it's the most challenging, and it takes the most practice and the most years of work to perfect. And that's what I'm the most proud of. Thank you. If I find an area that is tender and I just inject into that area, I'm hoping that it works, right? If I look at that area with an ultrasound and I find a specific problem, right? If I see a knee that's swollen, or if I see a tendon that's partially torn or has increased blood flow or has little calcifications in it, I can see very precisely where the problem is. Then I can actually take a needle and follow it to that exact location, right? And being able to do that increases the success rate far above what other people are able to do, right? And I'm not the only one that does this, but there's not very many of us.
Okay, wait, what do you mean by follow it?
Ultrasound guided procedures. So I can use an ultrasound machine and I can see the needle from the moment it enters your skin all the way to the target, whatever it is that I'm treating,
Okay.
right? So if I do, for example, there are studies that show knee injections. Everybody thinks, and V knows this all too well because she came from the orthopedic community, and I did that for the first 5 years of my career. Any guesses in a trained orthopedic surgeon, what is the percentage of accuracy? How often are they actually in the knee joint when they're trying to be in the knee joint? Want to make guesses?
To do what?
30%.
If I'm going to inject a knee,
5%.
5%? It's higher than that. If I'm going to inject a knee and I'm not going to use guidance, how often am I actually in the joint? 65%. Which isn't terrible. But if I'm going to put in something that is really valuable and there's not a whole lot of it, so we're going to use a vial of an amniotic fluid or a stem cell allograft product that's only got 1 cc of fluid, I better not miss, right? So I'm going to use, in my office, it's using an ultrasound machine to guide that to the joint and be able to watch in real time as I inject into the joint capsule, right? And that's something that I do and that I train all over the country and even occasionally internationally. And it's something that I'm super passionate about. Doing this kind of stuff is a natural bot. Somebody asked me this earlier, well, how did you get into this? When you start using ultrasound and you start seeing things that other people can't see, unless they get an MRI and they've had tons of training on how to interpret an MRI and all that kind of stuff. You can do things real time in the office with the patient in front of you. You start seeing things that nobody else can see. Mm-hmm. And then you start wondering, well, how do I treat that? What else can I do? this patient's been through therapy and anti-inflammatories and steroid injections. Maybe some of them have had surgeries. What else can I do? I'm a non-surgical guy, right? I can't open them back up. So naturally leads you to look for things that are up and coming, that have a little bit more cutting edge technology that I can provide that will make those patients feel better, right? And that's how I got here. And some of the products may be a little bit more cutting edge and or a little bit more on the fence with the FDA than others, but that's my job as the medical director to figure out how to find the right products and to make sure that we're all safe, me and the patient included. And I hope that I've done a good job of that here at the Regen Room. I'm super proud of what we've done. I love this place. I wish I was able to be down here more often. But V has done an incredible job. She's learned a lot. She's been in the orthopedic world for a long time, and I love having her as part of the team. So,
do you have any questions about stem cells or regenerative medicine? Yes, ma'am.
Oh, I have a lot of questions.
Pick your favorite one.
So like you hear, I'm a physical therapist. I work in orthopedic, or I did. I'm retired now. But you hear a lot of complaints about, well, it's just bone on bone. What do you do for that?
Yeah, so bone on bone is tricky. I will tell you that even in the worst cases, generally we can make bone on bone arthritis feel better. The problem is that actually regenerating cartilage and actually giving them visible changes on an image, whether it be X-ray, MRI, ultrasound, or anything like that, is incredibly difficult to do. So it really depends on what the patient's goals are, right? So
I would think it'd be pain relief.
Right,
So I can walk out
that's what I'm getting
pain.
at, right?
Okay,
So
pain.
when we're talking about getting people out of pain, getting their activity back to a level where they're able to exercise, they're able to be in better cardiovascular shape, right, better fitness, those things are relatively easy to do with things like hips and knees and ankles, right? Where it gets to be a challenge is figuring out where the value is for that patient. If I can only give you 2 years of relief, if I can make your symptoms better, by 60 or 75%, and I can make it last for a couple of years, is that enough to make it worth your investment? And I can't answer that question, right? And there are not a lot of papers, there's not a lot of studies, like huge studies out there that show that kind of data. But
So at the end of 2 years, can you do it again?
you can. Now, there's nothing in our portfolio that keeps you from being able to do anything else a second time or switching gears from one thing to the next. The only thing that interferes with what we do is if you've had a steroid injection in the preceding 4 to 6 weeks. It's just not a great idea. Or if you're on oral steroids, that's not great. And Rhonda asked me earlier about what contraindications are. So steroid use is one, pregnancy is another, active cancers probably a safe third one. We kind of want to stay away from that, even though there's no evidence to show that it increases the activity of cancer cells. We don't want to mess with that kind of stuff.
But to add on to that too, what the point is, we're starting to see a little bit of a trend, or at least a conversation around being more proactive and using regenerative medicine in a preventative and a proactive way, so you don't get there, right? I mean, people are starting to learn that you get one body, and when it wears out and you let it deteriorate to
Is that news to anybody here? You get one body?
then it's kind of gone too far. Surgery may be your only option. So there's a lot of things that regenerative medicine provides in the way of options upstream of that surgery or that stage 4 or bone on bone that you can do.
Getting people to make that decision is difficult. I've always said my best or the most ideal patient for me is like a 35-year-old who's had an ACL tear 10 years ago, who has no pain, who has no swelling, who has no problems currently. But if you've had an ACL tear and a reconstruction, you know you're going to develop arthritis. Right? You know it's coming. And so getting people to think that way.
I don't understand. I mean, why do you say that? Like an ACL, that's your tendon. Why do you think a torn tendon is going to make your joint?
No, it's a torn ligament, and what it does is it changes the stability of the joint, and so the surgical techniques that we use right now are not able to recreate the ligament precisely. Even the